It is a huge, huge honor for me today to be in the office of Dr. Ed Carlson, who is a very distinguished endodontist in my backyard we're in Mesa, which is a suburb of Phoenix. Mesa is what, the fourth largest city in Arizona?
And it may be even increasing a little bit.
And I heard it was the 17th largest city in the United States or something.
It's been a good place to live.
And Ed's just a really good guy. And how many associates do you have now?
Right now we have two. We're
just
looking
those-
at bringing another one in.
So you have
pretty
three.
swiftly. Mhm.
And Ed, it's an honor for you to be here. You're 61. You're turning 62 this year. We're both short, fat, bald guys with 4 kids. I think the funniest thing Ed ever told me. Tell him the story. Tell him the story.
I was at a dental convention. I was actually doing pro bono root canals for somebody, and with my back turned, a member of the state delegation came up from behind me, and he actually sent a gal over first, and she started flirting with me and wanted to know what I was doing when I was done with root canals. And I had no idea who she was. I was just a little bit flustered, and she could tell I was a little flustered. And right then, a guy came up from behind me and kissed me on the top of my head and said, "Man, I just love seeing this guy here." And then I turned around to look to him, and I had no idea who he was. And I know he thought I was Howard.
But the same thing happened to me because you sponsored my first bike race. When I started doing tries, the first race I ever did was a 70-mile tour to Mesa. And I wore your jersey, Super Endo. And 3 times during the race, someone's coming up behind me yelling, Ed, because there's this bald guy wearing his Super Endo shirt, so they just knew I was the endodontist Ed. But thank you.
Both a little bit broad-shouldered.
Thank you for supporting that race.
You bet.
But before we these podcasts are great because they're mostly kids. I mean, everybody that contacts me is under 30. A lot of them are from the dental school right up the street from you.
Right.
AT Still and Midwestern are huge of these podcast fans, and they're multitasking. And I just think it's an honor that you're going to sit there and spend an hour with them telling them what you've learned in endo. But before we jump into endo, which is a specialty, you were in another specialty, which was public health. Let me read you his bio. Ed was raised in Utah, son of a turkey farmer. There's so many jokes there that I'm just, what's your best joke for raised as the son of a turkey farmer?
Oh, I don't know. They're not as dumb as the guys who raise them.
They're not as dumb as the guys who raise them. I love that joke. You attended BYU with a BS in zoology. Were you thinking about vet? Was vet your alternative to dentistry?
Well, no. At BYU, they didn't have a biology degree. It was either zoology or microbiology or chemistry. And so I picked zoology because I didn't like looking through a microscope, ironically enough, because that's what I do all day now.
And then you have minors in chemistry and English. Then you attended West Virginia Dental School, 79 to 83. Then you worked as a general dentist for public health as one of the 9 specialties. You worked for the Indian Health Service in Fort Duchesne, Utah. Then you were a lieutenant commander in the United States Public Health Service. Then you went to endodontic training in Long Beach, California, and board certified endodontist. Co-founded the American College of Endodontists, fellow in International College of Dentists, and then you established Super Springs Endo, and the Eagle Scout awarded Silver Beaver in 2013. So I want to start off with, before we jump into endo and implants gets all the attention, but the specialty public health no one ever talks about. What did you learn from your years of public health, and what do you think public health dentists? What is their mission today? And because a lot of kids might be listening to you right now that are thinking, maybe I might do public health for.
Well, the reason I did public health is because I got in dental school, and one day in a mailbox at school, I received a notice saying all my dental school could be paid for, and I could have a monthly stipend if I agreed to work for the government for a couple of years. So I signed up. I had a 3-year commitment. I ended up working 4 years. I was on a wonderful little spot in Roosevelt, Utah, and working with the Ute Reservation, Ute tribe. And I did mostly bottle mouth baby caries. Most of my patients were under 10 years of age. And I learned real quickly I didn't want to be a pedodontist. I learned the value of fluoridation because they had fluoridation on the reservation, and the Utes did not drink it. They wouldn't drink the fluoridated water. And all the white people in the area did. None of the white people had had caries, but the Indians did. So it was.
And why did they not drink the fluoridated water?
I think they just liked their own source, their own wells, or wherever they could get it, just because it was a traditional way. But they were wonderful people. They treated me great. I played on their tribal basketball teams and softball teams, and they'd show me where to go fishing, but they never would take me hunting.
Why do you think that is?
I think they didn't want me to find their elk.
Well, it's funny because
but it was a great experience.
You noticed that the non-fluoridated Indians had higher decay rates than the white people drinking fluoridated water, and race was the first thing that caught my mind. I didn't realize going to UMKC dental school, the hardest requirement to get was your chrome steel crown for your pedo. And every Tuesday, some dentists who passed away left money, and they would every Tuesday a bus would go pick up the second graders and bring them in, and we were all excited to see this fresh load of kids coming in from the school, and we'd say, well, do you have a toothbrush? Nope. So you don't brush your teeth? No. Do you floss? Nope. And then you're like, okay, I'm going to find my pulpotomy. And you take bite wings and they'd have nothing.
Right.
And then I graduated, I moved out here to Phoenix, and I'm in Phoenix, but they call it Ahwatukee. Mm-hmm. And so I'm in Ahwatukee, and, if 5 white kids came in, 2 of them needed a pulpotomy chrome steel crown. And that made me call the CDC, and I said, I can't believe I got out of dental school and never learned that black people have much better teeth than white people. And the guy's like, what are you talking about? And I told him, Dylan, he goes, yeah, well, you went to dental school in Kansas City where the water's been fluoridated, and you live in Phoenix without water fluoridation. And so I'm just like, oh, my God, it was just such a – and so you lived through this too.
Right, and we did the Head Start exams, and 50% of the kids under 5 had baby bottle tooth decay. So they were decayed multiple molars and front teeth. And I actually wrote a paper that was presented back in Washington, D.C., having to do with the incidence of that amount of caries. So
what would you say to a fourth-year, third-year dental student right now who's thinking, well, maybe I'll do a couple of years in public health dentistry?
I think it's a wonderful experience to give you a chance to see the specialties of dentistry, to increase your skills, to learn how to relate to patients. The first day in public health, I saw things I never saw in dental school. And doing a stainless steel crown on a 3-year-old was pretty scary the first time. Then it got very routine. You learned how to manage patients, you learned how to work with staff that were diverse, and they end up paying for education. And I think there's a lot to that right now, too. I think there's a lot of trade-offs that if you agree to go work for the public health, that they forgive a lot of your education, and I think it's a chance to give back. And you may get bumped back a little bit from where you're ultimately going to live, but in the long run, it paid big dividends for me. It helped me decide what specialty I wanted to go to, because I would never have picked endodontics had it not been for my public health experience.
Really?
Really.
That's interesting. And Arizona is 25% of the state is Indian reservations. I think we're the most Indian reservations of any state. Is that right?
I don't know that statistic, but that wouldn't surprise me.
I've heard there's like 217 Indian reservations, and Arizona has like 19. But as far as land, I mean, a quarter of the state is Indian reservation, and they've had huge problems with decay, obesity, diabetes. Do you think that's improved over the last in your lifetime since working on public health?
Not that I have seen. It was a terrible problem. Diabetes was a terrible problem with the people that we treated as well, and I haven't seen that getting any better. My wife actually has a half sister who's Navajo, and we have contact with them, and they still have a lot of the same problems on reservations today as they did before.
Do you think that's a genetic predisposition? I mean, comorbidity, there's many variables, but do you think a genetic predisposition?
I think there's genetic, and I think there's cultural. So I think sometimes when you have younger families, so married younger, they don't have the maturity to take care of children, so they start feeding them things to help the kids be quiet. I think a lot of things contribute to the dental and overall health problems that they have.
Now, in Ahwatukee, I'm across the street from the Guadalupe Indian Reservation, which still to this day doesn't have a dental office. So a quarter of my practice has always been Guadalupe Indians, and it's very challenging. I mean, when they bring their patients in the room and they're pipetting them Mountain Dew in their mouth to a crying child that's screaming from a
Sure.
toothache, and you're like, and they're feeding it Funyuns
Sure.
in my dental office.
I took a photograph as part of my lecture when I presented my paper back in Washington, D.C., of a mother that brought her baby in with a bottle full of Coke, just drinking Coca-Cola.
And that's where I'm so excited about the American Dental Association now, is because, they never did the marketing when we were young, which would have been television. They weren't on ABC, NBC, CBS. But now, social media, now all the dentists are posting all of these memes and public health, brush twice a day, pictures of baby all tooth decay. And I'm so excited. The reason I work my Facebook page so hard is because I know all these dentists are sharing it. And I think social media might actually start making a dent in public health. And I wish dentistry would spend a lot more time focusing on public health and preventing disease than all the talk about drill, fill, and bill. So now this is Dentistry Uncensored. I want to get to some of
You mentioned Facebook. Can I just throw something in here?
Yeah.
So Facebook's ingenious about the way they just remind you, this is what happened 5 years ago. Would you like to post it again? Well, I got one of those. 5 years ago, this last week, I had a root canal. And I came in, I broke off a cusp of a tooth and had my partner do it. And halfway through, I said, stop right there. Hand me a mirror, go get a camera, and frame this so it looks like I'm doing my own root canal. So it shows the x-ray in the background. From the back of my head with a rubber dam, I'm holding a mirror and I've got the file up inside the tooth. And I posted that on my Facebook page. And at the time I was working with some Boy Scouts. The next week I heard one scout say to another scout, don't mess with him. He does his own root canals. So you're right. You can put a lot of things out there, and it raises eyebrows, gets awareness, draws attention to the individual dental practices in a way that you just can't advertise any other way.
And congratulations on the East Scout. I grew up with 5 sisters, and about the only boy stuff I ever did was always in the Boy Scouts. Okay. I mean, it was a big part. I got to go to Cimarron, New Mexico, and climb Mount Phillips, Philmont Scout Ranch. I mean, that's just, God, that was some of my greatest childhood memories are all Boy Scout stuff. And then I go home back to my 5 sisters playing Barbie dolls. So Ed, let's talk. This is Dentistry Uncensored. Let's talk about some of the dark side of endo. When I grew up in Kansas, everybody did Sargenti. And a lot of these kids, they'll graduate from dental school and they were educated by sharp endodontists like you. And then they go get an associateship, and a 60-year-old dentist says, oh, that's bullshit. I've been spinning this paste down there, and it's got paraformaldehyde. It's going to kill all the bugs. And they have almost conspiracies of why. But, it's not ever talked about, but I guarantee I look at the lawsuit deals. I mean, in just the last year, I've seen $1 million settlements because the N2 Sargenti paste went out the apex and pickled the inferior alveolar nerve, and it was a full-blown paresthesia. Do you ever see Sargenti anymore, or is it completely gone?
No, it's still around. I don't think that it's actively being done in this area very often, but I still see cases that were treated with Sargenti. I see cases that were treated with silver cones, and patients that were treated in other countries and here locally. And I think there are lots of ways to do what we do. And I know that those endodontists in my school in West Virginia were adamant that gutta percha was the only way you could do things. And I get out and I see cases that have had Sargenti that have worked for a long time, and silver cones that have worked for a long time. And I'm not proposing anybody use those and do that, because the mishaps happen. They're going to happen with anything, but they happen more often with things that you're not taught in dental school, things that you'd pick up on a weekend because your Uncle Lenny said, hey, I saw this on TV, let me do this. So I would stick with the tried and true things. I would only change if you have a very valid reason to change. You don't change for just the ease of doing it and just to make money.
So Phoenix is a big retirement area. If you're west of the Mississippi, it's okay. It's no big deal. If they're Minnesota, North and South Dakota, they retire to Phoenix. If they're east of Mississippi, they go to Florida. So we have a huge abundance of senior citizens out here. And when you see a silver point endo and it's lasted 40 years, does that just reinforce that it really doesn't come down to how you obturate a tooth? It's how you clean and shape and disinfect the tooth, and that these things just got so cleaned and disinfected that they worked, or do you think there's other variables involved?
I think there's a lot of variables. I think number one, it begins with doing a good technique and using good materials. And I think silver cone is a good material. When it corrodes, it's antibacterial. But the corrosion byproducts of silver sulfides, they cause problems themselves. But they don't corrode if the coronal restoration doesn't break down, typically. So if there's something else, a crack in the tooth or decay underneath the restoration, the saliva, moisture gets in, they're going to corrode. And then they're going to have problems. But if they stay protected in their own little mausoleum, if you will, they can stay there a long time. That's what I see.
So Ed, I want to go to a very controversial thing that I don't think a lot of dentists like to look at objectively. They bring bias to the table. There's a lot of dentists out there that think that these silver fillings lasted twice as long as composites. And a lot of people say, oh, the silver fillings, they break all the teeth. But then a lot of people are saying, well, 40, 50-year-old people, their teeth are breaking regardless. And a lot of the amalgam people are saying, I put in these amalgams and they lasted 25 years. I've been putting in a lot of the tooth-colored stuff. And 5 or 6 years later, they had recurrent decay. And it wasn't the type of recurrent decay they saw under amalgam, which was a little bit of decay. They're taking out some of these white tooth-colored fillings, and they're saying, I had to take a number 4 round bore. It was mush. So my specific question to you, do you think switching from amalgam to tooth-colored composite increased your business, the endo business for the endodontists around the United States, or not really?
I guess if I had to say, does it, I would say sure. I think the way I look at it, every time a tooth gets worked on, the nerve can get bruised. And so if work is being done needlessly and the filling's being taken out just because it's a silver filling, I'm not a fan of that. Because I see a lot of pulps that have gone bad. I can share one story with you. I had a patient come to me years ago. She was a nurse. We know sometimes about nurses. But she was living on the street with a dentist. And the dentist, husband and wife, became very good friends with this nurse, wife and husband. And the nurse and her husband were being transferred to Georgia. And she had a mouth full of silver fillings. So she went to her friend, the dentist, who she trusted and liked, and who I personally know is a good dentist, and said, I would like to have all of my silver fillings taken out before I go to Georgia to make sure that I don't have to look for a dentist and not run into any trouble. I just want to get it done. It's that time in my life I'd like to have it done. So over the course of the next week or two, he changed out 12 restorations. And over the next 2 months, I did 8 root canals. And none of her teeth were hurting. And it ruined their friendship. And she filed a complaint with the board. And I know he didn't do anything wrong. He just worked on the teeth. And the restorations look great, but just the fact of working on those pushed those over the edge. Now, that doesn't happen all the time. That's a pretty rare case. But I think if a restoration breaks down and needs to be replaced, boy, let's replace it with the newest and the best stuff we got. But just to take one out and do it.
What is the newest and best stuff we got?
Well, that's a good question, and I'm not a restorative dentist,
But
so
from
I still think
from an endodontist point of view.
I can tell you if it were my back tooth, it would either be gold or amalgam.
Yeah, all of mine are gold.
Yeah,
and my boys, I put gold in their mouth, and I just don't get the culture. What I can't figure out the most about women is they'll put gold in their earrings, their rings, their necklace, their ankles, their belly button. I mean, they got gold on every appendage of their body, and then say, "Can I put a gold tooth on your second molar?" And they're like, "Are you crazy?" And I'm looking at her, and she's got like 6 gold things in one ear.
I know. And she's the one that can't stand needles either.
Yeah. I just wish we could maybe if the dental society's got like the most rocking hot women to start getting gold fillings, and maybe if Madonna and Britney Spears and those girls were all sporting gold crowns, maybe it
I'm
would
with
take
you.
off.
In dental school, I had some of my silver fillings replaced and put in with gold because we needed requirements to graduate. I still have those restorations, and it's been almost 35 years since I graduated.
I want to ask you
school.
another. I'm going to stay with uncomfortable questions.
Sure.
A lot of people on the endo threads on Dental Town, you can see how they're confused, and they're like, "Okay, I did it. I removed the decay. Everything's fine. I have a pulp exposure. What's the better way to seal that pulp exposure? Would it be to just go down and do the endo and you're sealing it at the bottom of the tooth? Or would you seal it right on the place? Some of the old school people say, well, if you put something like calcium hydroxide, which has a real high pH, it's kind of an irritant. It'll get the tooth to repair. Other people are saying, well, there's this $100 a gram MTA stuff that costs about the same as heroin or cocaine, and patch that on there. So I just want you to say, she's 25. She was doing an MOD, and she's got a pulp exposure, and she's got a pulp exposure. What would you recommend?
I think there's that's a great question, and I think there's conservative ways and there's aggressive ways to treat it, and then there's deciding, well, what would I do with my tooth? And I'm an endodontist, so for my tooth, I'd take the pulp out and do a root canal. But not everybody's in the category where that's the best decision, either as a patient or what I'd recommend. So I think it's based on the size of the pulpal exposure. And if we think it's curiously involved, if there's decay and bacteria that's very obviously already in that pulp chamber, I think that's an issue. But years ago...
Describe it. Most people are listening. Describe that pulp issue. I mean, how would she know looking?
If you've got a little pinpoint exposure and you can take a moist cotton pellet, don't use a dry one, but use a moist cotton pellet with just some saline or even tap water. Just put that over the pulp chamber and hold it with just a little bit of pressure for a couple of minutes. Take the cotton pellet away. If it's not bleeding, it's red, but it's not bleeding, that's probably a pretty healthy pulp. If it's bleeding and oozing into that area, then there's something still inflamed inside of there and you have to take out a little bit more. Well, pretty soon if you take out too much, you could get down to just the pulp stump at the bottom covering the roots. You can do the same thing at that level. You can do it at any layer where you have good, healthy, non-inflamed tissue. If you can stop the bleeding with mild pressure, just after 2 or 3 minutes, that's probably healthy pulp. But if it keeps oozing, it's not. Well, there's a trade-off. How far are you going to go down to keep exploring that? And then what's going to be the ultimate restoration? Every pulp that gets drilled into and even gets close is probably compromised at some level. So you have to decide, is it compromised where I'm going to have to put a crown on this tooth? And now if I have a compromised and a questionable pulp, I'm going to have to drill through the crown? Or do I take care of that right now and then put a crown on? So if it's if it's a young kid and the crown's not anticipated and you're going to treat it with a conservative restoration, I'd try to repair it. But if it's ultimately going to need a crown, I'd probably make that decision to do a root canal before I put a crown on and then have to drill through a crown.
And when you have a pulp exposure, how should dentists be thinking about treating a pulp exposure on, say, a 20-year-old kid versus a 40-year-old kid versus a 60-year-old grandpa?
Well, I think that my feeling is the principles are still the same. If it's not inflamed, you probably can get away with a little bit more.
So you think a 60-year-old man will heal just as well as
I think a lot of
20-year-old?
times they do, because there's a lot of secondary dentin already there. That process has already continued. You may be a little deeper down with that, but I don't have anything wrong with somebody doing a conservative approach and just repairing that, and if they're going to do a build-up for a crown, then get to that point. But don't commit to a crown till you give it maybe 10 days, 2 weeks, make sure it's out of the woods, maybe a little longer, and then do the crown.
And how would you treat that pulp exposure? Would it be calcium hydroxide? Would it be MTA? Would it be...
I still like calcium hydroxide.
Dical.
Yeah.
Is that the brand you use?
Yeah. Mm-hmm.
Dical?
Yep.
Who makes that?
I don't know if it's Dentsply.
Is it Dentsply?
I can't remember. My assistants order all this stuff.
Yeah, same here.
They squeeze it out and put it on a tab for me.
Yeah. So still just good old Dical.
I think that's great.
And then what do you put over the Dical?
And then I remember attending a seminar years ago by Bertolotti.
Mm-hmm. Ray Bertolotti.
And
do you know Ray Bertolotti's wife used to be in the same Catholic nunnery as my sister, Mary Kay, a cloistered Carmelite monk. And,
Wow.
yeah.
He got her out.
He got her out and married her. My sister's still in, but yeah, that's our
But I remember him, what I thought was just him being a heretic years ago. He said, just to protect that, etch around it, bond it, and there you go. And that works a lot. I think, again, you protect that little pulp, and you got the decay out, there's no bacteria, it's not inflamed. You build that back up and put a little insulation over it, I think it's going to work.
Okay, I want to ask you another stressful thing that these kids see. They're taking out an MOD amalgam because it has recurrent decay, and they got the rubber dam on, they got everything all cleaned out, but there's a crack on the floor. And they're like, okay, I took it out for decay, the patient didn't have any symptoms. Talk to these kids about what is Ed's mind thinking when you see a crack underneath an amalgam?
Boy, that happens every day, just about. I think that's a great question. And I think the first thing I always try to think, well, what would I do if it were my tooth? Would I hang on to this, or would I throw in the towel? There's different kinds of cracks. We often will see a crack going over the distal marginal ridge of a lower molar, disappearing down into the distal canal, but not coming up the other side on the pulpal floor. I don't hesitate at all to fill those teeth and inform the patient there was a little hairline crack. It doesn't seem like it's spread.
Fill the tooth with the filling, or fill it with an endo root canal?
I'm taking this position from a root canal standpoint, so I'm really looking at the pulpal floor. But if you're down above the pulp and you see that hairline crack, and there's no decay and there's no soft dentin, I'd sure be tempted to just shave a little bit of that off and put a little etch and bond and try to cover that up, and then put an on-lay or a crown over the top of that.
But you wouldn't necessarily go to endo?
No. If there's no symptoms, no radiographic sign that there's a radiolucency, you can't probe anywhere, the tooth has been asymptomatic, I would not commit that tooth to endo.
What would make you commit the crack to endo?
If it had some decay and you had to keep softening or chasing that out, and it got down to a pulpal exposure, and then you got into the pulp and you could see where you removed that the crack was still at the bottom of the tooth, I'd say send this to an endodontist, let him look at it with a microscope, let him find out how extensive that crack is. If that crack goes all the way from the mesial down into a mesial buccal canal, back up across the pulpal floor into the distal canal, back up the distal wall and across, those don't have a great overall prognosis. And it's sad because a lot of them are asymptomatic, but
And what are you thinking when you see a crack and it's just almost like barely, almost translucent versus black? I mean, sometimes a crack just looks like black pen, and other times it's like tooth colored.
Yeah, I guess I would think that the tooth colored one's probably a little more fresh, especially if there's been a restoration in it. I do not like to see teeth with cracks in them with no restoration, but now have symptoms of pulpal problems, because that crack is extended in the pulp somehow. And if it's that extensive and that small, you can't see these on an x-ray, and you can't see them the extent all the way they go on a microscope either. So you got to really have a good discussion with the patient. This is what I do with my teeth. These are the possibilities. Since you're not having any symptoms, we think we can hang on to this tooth for a long time. A long time is different to everybody.
And one thing that might be flying over your head, one of the reasons some doctors can sell so much dentistry on their scan is because when you give a patient 4 options and you don't have, what I would do for my tooth. I mean, when you give someone 4 options, say, what do you want to do? They're looking at you like, I thought you were the doctor. But when older guys say, well, you could do these 3 things, but you know what? If it was my tooth, I'd really do this. This is what I would do for me. Then the patient, it's a lot easier to say, okay, well, let's do what you would do for you.
Right.
And I see the younger kids given 4 options, and the patient's looking at them with a blank stare like, well, aren't you the doctor? I mean, am I supposed to, a doctor that treats himself as a fool for a patient?
Though that's a great observation, and Dr. Barney here, he's blessed with young genes, and so he looks young. And some people think, "Oh, are you really out of dental school?" Well, I came out of dental school bald, and so I had an advantage where people thought I looked older than I was. And so
I know.
you're right, and I think talking to them in lay terms helps communicate that, and you have to really believe what you're saying. You have to be sincere. If you're pitching a sales pitch, it's not going to come across as well as if you're really talking from your heart. This is what I've seen. This is what I do, and there's no getting around the fact that having experience adds to that depth of understanding and what you can do and how you can present that.
I'll never forget when I opened up in '87. I was always doing second opinions from these two dentists that practiced together across the street, and they were like 7 and 8 years older than me. But I was the bald guy, and they'd always say, "You know what? They're so young. I don't even know if they, I'd rather see what you thought was better." And that bald head, they just thought I was their dad almost. It was just crazy.
Right.
I want to go back to that. Okay, that Dical versus MTA. What are your thoughts on MTA? Do you ever use it? And why is it so darn expensive?
I don't know why it's expensive, and I do use it a lot. Where I use it is if there is a perforation. So let's say we're looking for a really calcified canals, and there's an opening into the furcation, a perforation, and it's not very big, but it's bleeding. It's good, healthy tissue. We treat it just like pulp. So if you get that PDL to respond and calm down, then that's where we put MTA. We put MTA when it's a surgical approach on apicoectomies. There's a lot of various materials to use on that too, but MTA is probably used by more endodontics than other products. But I don't use MTA coronally for a pulpal exposure because it has a lot of staining ability. It's a medical grade Portland cement is basically what it is. So it has calcium and other derivatives in it. Mahmoud Torbinejad is one who developed that out of Loma Linda, and it's just maybe a coincidence.
Is he a friend of yours?
I know Mahmoud.
Can you email me, Howard at Dentaltown, and CC him?
Sure.
I'd love to talk to him about that.
Yeah. And I remember talking to him about how he developed it. He said his dad laid concrete for a living. And he said the concrete was impervious to moisture and everything else once it's set up. So I thought if it can work on a sidewalk, it ought to work in a tooth. So he went through all kinds of renderings of different formulas and came up with MTA. They also make MTA where it doesn't have the opacity to it, so that you have the tooth-colored MTA. We have found out by trying to do pulpal regenerations and other procedures, that stains teeth as well. So we're just not a fan of MTA in a coronal part of a tooth because that leads to darkening and making a tooth look bad.
And that's...
But a posterior tooth, it could work, but I wouldn't do it on an anterior tooth.
And that's funny because that's how a lot of us older dentists back in the 80s who had swimming pools, we'd see how the muriatic acid would clean the pool. And then I just went to my pharmacist and bought muriatic acid, which is pool cleaner, and I mixed that up with some pumice in a prophy cup, and my God, stains on teeth. They might have the brown, the rust stains, just weird stuff. And it just polishes out those enamel pearly whites. And
I can tell you, when I did work for the Indian Health Service, I had a lady come in with her husband once, and she said, "Dr. Carlson, would you tell my husband to quit brushing his teeth with Ajax?" I said, "Well, they do look white." He said, "It works, it works."
Ed, a very stressful question a lot of dental school graduates and a lot of dentists are having is they're coming out of school $350,000 in debt, and they're told by a lot of companies that if you really want to do quality endo, you need to buy a $100,000 3D CBCT X-ray machine from Carestream or Galeos. For someone to do molar endo to the level you're doing, should they buy a $100,000 3D X-ray machine? How big a part of that is your practice? How often do you use it?
Well, to cut to the chase, the answer is no. You don't need a cone beam to do root canals. You don't need a microscope to do root canals. There's a lot of things you don't need to do root canals because guys have been doing them for years without them. And they have very successful practices with long-term success. But I like to look at things that make my life easier and less stressful and that bring value to the practice. We do have a cone beam here. I use it less than any of my other associates.
What specifically, which cone beam did you get?
We have the Merida.
The J Merida?
Yes.
J Merida?
Yes. And we've had it for about going on 4 years.
What did you pay for it?
I think we paid $115,000 for it.
And are you glad you bought it?
Yes.
Okay.
And that being said, I probably ask for 1 scan a week out of all the patients that I see a week, whereas my partners might get 3 or 4 a day. They use it a lot more than I do. I've looked at it as it helps us see things we couldn't see before, especially for resorptive cases. So you can see the extent of the external resorption or things that are going on to let you know if it's even feasible to put a filling internally or if it's all going to spill out. But you still can't see microfractures with a cone beam. You can see curved roots. You can see that it has multiple canals. But the cone beam doesn't help you get into those. You still have to mechanically find those and get into those. And there's times when I've been doing a case that's difficult that I've stopped and I've taken a cone beam and I've could see where I'm making the access and I'm just barely off where I want to be for the canal. That helps me redirect. There are cases like that. But by and large, my feeling is that the cone beam helps us satisfy our curiosities, and it's kind of a crutch more than it is a necessary tool. So
And
that's probably not what the mainstream endodontists are saying, but that's the way I look at it.
And there's 3,800 dentists in Arizona, and most of those, well over half, are right here in the valley. If one of those guys or gals is listening to you right now, would you ever let them come by your office? Do you ever do that? Do you let dentists observe?
Absolutely. We have that almost on an ongoing basis. Not every day, but we get phone calls more than once a month asking if people can come by and watch us work and explore the office. There's a lot of pre-dental students. There's a lot of students that want to get into specialty that come watch. There's a lot of hygiene students that need to get some credits. So we have people here all the time watching what we do.
What about just general dentists?
Sure.
Now, what are your thoughts on that? What, like, if a general dentist comes in here, because a lot of, I think smart dentists go watch a specialist, a friend of theirs up the street. I don't understand why they have to get on an airplane, fly 4 hours across the country, pay $3,500 for a weekend course when there's someone far better than that instructor right in your own medical dental building. But a lot of them feel like they're thinking, well, why would Ed show me how to do a molar root canal if that's going to hurt his financial pocketbook? Because I want to learn how to do molar endo to do molar endo. Why would you let them observe?
Well, years ago we started a seminar series called Inner Space Seminars. And the whole idea behind that was to show a dentist what we're capable of doing. But my approach was, let's show them how we do it. Let's spell it out. You go to an NBA basketball game, you watch people dribble down the court and shoot, and they're showing you how they do it. I can't do that. And when a general dentist comes here and they see everything that we put into pulp testing and to isolation and to finding canals and sterilizing and keeping things the way that we think it ought to be, most of them think, there's no way in heck I really want to do all of that if that's what it takes. And it doesn't take that on simple cases, but sometimes it takes it on the tough cases. So if we let people come in here and they pick up some tips and they see the scope of things that we can do, then it helps us, and it helps us with goodwill in the community. So we're glad to do all of that. Anything that helps the overall dental health, I think, is good for the population, public in Arizona.
It's the it's the one thing that I've noticed in all successful business people is they always think in hope, growth, and abundancy. They never think in fear and scarcity. And the dentists, it seems like, that view the other dentists in their same medical dental building as competition, and their whole life they go avoiding the other person. That they're always miserable and they're never really successful. And guys like you who don't think in fear and scarcity and just think grow the pie. And I think the street smart dentist can learn a hell of a lot about it, endo by observing great ones like you. But go ahead.
Where this all started was years ago, I was working with another associate here in town. I was actually his associate and became his partner. And then we started to get busier than we wanted to be, and we needed a larger location. We found this property with other dentists and decided to purchase it and build our office. And just as we were getting ready to do that, he said, you know, I'm getting too old. I don't want to do this. I'll let you just run with it, and let's stay friends, but I'll stay here and you go there. And we've been friends over the years, and he's a wonderful guy, Mike Bailey, here in town. And I learned a lot from Mike. But because I was going to start out on my own, I thought, it's going to be my office. I need to have it my way. I need to find out what I'm made of. And I sat down and I wrote a vision statement. And I thought, when I walk to work, what I want it to be like, what do I want it to feel like, and what do I want the end result to be. And so I spelled out that I wanted people to come into our office and to have kind of a wow experience. And in order to do that, I need to support the general dentist. I need to help with continuing education. I need to reward my staff in an abundant way. And we need to be a team. And so a lot of these things that we have done here are reflected in that. So one of the things I would encourage general dentists to do is to sit down and say, how do I see myself? How do I want my practice to be a reflection of my personality rather than just what they told me to do in dental school? But if it doesn't reflect your personality, you're not going to have longevity with it. I think you have to be consistent in all aspects of your life. Your personal life, your spiritual life, your family life, your business life, your dental life, they all have to be consistent. And you're right. If you have an attitude of abundance and generosity, it's going to come back, and you can be successful. You'll be happy.
Absolutely. You opened up a can of worms when you talked about resorption, internal, external. Okay. So I know their minds are thinking, how does an endodontist look at internal and external resorption differently? How is it treated differently? Talk about that since you did say it, not me.
Sure. Well, there's almost never pure internal resorption. There is. But 98 out of 100 cases that a dentist sends over to me and said, would you please evaluate this internal resorption? It's external. And cone beams show that really, really well, with the periodontal ligament being irritated somehow and the cementum and the dentin being resorbed away. Sometimes where there's no contact at all with the pulp. But it wraps around the pulp, and pulps are vital, but the tooth is being eaten away. And we don't always know why. I'm always assume it has to do with trauma, whether it's ortho trauma or regular trauma. But I'll bet half the patients I have where I see that have never had ortho. And they don't remember being hit in the mouth with a softball.
True or false, it's mostly seen in boys. Boys have more trauma.
I don't think that's true. I see it a lot on girls, too. So
you see it a lot on girls who didn't have ortho
and women.
So what are you thinking it might be?
I just think that it's our bad luck of the draw. I know that in cats, for instance, there's about 65% of cats have tooth resorption. So I've thought, I have a brother who has his PhD in chemistry, one who is into marketing. I have another brother who is a patent attorney, and all six of us boys grew up on the farm. We thought we ought to develop a cat food that is aimed at the higher end owners to fight cat resorption, tooth resorption in cats. Haven't come up with that formula yet, but when I retire, I might. I think we don't know. We don't know. That's why they call it idiopathic, and so we really don't know what's causing.
And what does idiopathic mean?
We don't unknown cause.
Unknown cause.
Yeah.
My job is to guess questions that
Okay.
thousands of people out there answering. So when you see external resorption, when do you say I'm going to do endo, and when am I going to extract?
Well, most of the time my argument has been if there's a pulpal problem and this seems to be a slow process, let's do the root canal and hang on to the tooth as long as we can. If it's an extensive problem and there's no pulpal problems, I don't recommend any interference at all. Just let it run its course. When it starts to bother them, take the tooth out. Because changing the internal pulp on a tooth with external resorption doesn't do us an awful lot. almost does
And
nothing.
you know, it's funny because it's embarrassing how much I've learned over the years from the patients who didn't accept my treatment. When I got out of school, if a baby tooth didn't have a permanent tooth underneath it, you had to pull it and do a bridge or an implant or something because it was going to fall out anyway. Well, everyone who didn't accept the treatment, 28 years later, that baby tooth's still sitting there. And it's the same thing with external resorption when you said, well, you know, you need to do a root canal. We need to do that. And because I literally thought in 87 that something in the pulp might be feeding, you know, the bugs. And the people who didn't get the root canal, the external resorption, a lot of times it was still there 10 years later.
And I had a case. He was the brother. My patient was a CPA, and his brother was a state senator, a prominent guy on the radio and TV all the time. The dentist sent this gentleman over for root canal because he saw internal resorption on tooth number 28. And we could tell that it was external resorption. And the only way to treat that and slow that down would be a surgical approach on the facial where that resorption was, which would then violate the pulp, which was normal. We weighed everything. We decided to do a root canal, sent him to a periodontist who then laid a flap and did the surgery. And he ended up with a dehiscence of about 12 millimeters, and the tooth spiraled downhill, and he lost the tooth in a couple of years. Whereas if we'd have left it alone, he might still have the tooth.
Okay.
He might not, but...
Same question I asked you on the CBT scope. If I want to do great endo, do I need a scope?
Yes.
Interesting. Don't have to have a CBCT, but you have to have a scope.
And I guess I should qualify that because I went through all my training without a microscope. And it wasn't until about 1992 or 93 that I got a microscope. To me, the revolutionary changes in endodontics for me in my 26 to 30 years has been digital x-rays and a microscope, because it just takes the stress out of finding those extra canals. So I have colleagues of mine that are still in practice, and they find those canals without a microscope. It is not malpractice to do a root canal without a microscope, but it sure makes it easier.
And what microscope did you get, and how much did it cost?
Oh, let's see. I have an Urban microscope.
URBAN?
You know, I'll have to go look. I have to tell you, when I bought my microscope, I went to a course by Gary Carr down in San Diego back in 92 or 93, and I called him up, and he said, Ed, just do it. It'll change your life. And he said, I guarantee you're going to get a second one if you get one. I paid about $25,000, and I had 2 scopes for the assistant to look through. And a month later, or 3 months later, I bought another microscope. My first one was floor mount, so I could roll it anywhere, thinking I'm going to do that. They're so dang heavy, you put it somewhere. I didn't even use it for a month because it was in the way. Then I thought, I better use it, and then I was hooked. So then I got a ceiling mount one, but then it's always in one spot. And then I got a wall mount one that's in the way of other things. When I built this office, we have 6 operatories, we have 6 scopes. They're all mounted from the ceiling. They're all the same. And
What are the 6 scopes now?
they're all the
Urban?
yeah.
And that was it's URBAN.
I think so, but
Let's add
it's
that to
global.
the notes. Oh, it's global.
Global surgical.
Oh, I thought you said urban. So
well, I think they went by 2 names. So global surgical.
and they're out of St. Louis.
Mm-hmm.
Okay.
They are. So,
Did I ever tell you my Gary Carr
but
story?
I paid for these so long, I don't go look at the brand name anymore.
Did I ever tell you my Gary
No.
Carr story? So he was putting on this endo course, and me and my buddy really wanted to go, and they said, well, it's endodontists only. So I thought, well, you know, I'll just lie. So I wrote endodontist. And so I went in there, and everything was going great, and then I was talking louder than I thought, but anyway, I was in the back. I didn't think anybody heard me, but he overheard that I was a general dentist from Phoenix. Oh, my God, he was so mad. He was mad as hell. And I said, so is he still that way? Is he like, you're either endodontist or not? Is he still, you still talk to him?
Not very often.
Does he still have his endodontic software for endodontists?
He does. And you're kind of either in that club or not in the club. And we're not in that club.
And what's the name of his software?
Total Dental Office, TDO.
Yeah. You know, my
TDO.
best friend from 7th grade all the way to the end of dental school, John Lease, we actually met in scouting in the 7th grade, and we both went all the way through dental school, University of Missouri, Kansas City. He's an endodontist out in LA, and he uses Gary Carr's TDO. And he did tell me not to go to the course.
And Gary does marvelous work. I have referred patients to him back before I was really getting into a microscope. I thought he handles cases that nobody else can handle. And so I've referred cases to him, and he treats patients wonderfully well.
Yeah, the endodontists love him. The endodontists love him. And they and he into racehorsing too?
Now that I'm not close enough to know that, so he could be
something with horses.
He's a pretty amazing guy. He's developed a lot of tools that came along because we have microscopes and ultrasonic tips, and he's innovated the way we do an awful lot of things.
Let's go to another.
Deserves a lot of credit.
Okay, so I'm going to ask you the same question. Another amazing endodontist, Ben Johnson in Tulsa, Oklahoma, started Thermophil. Is leaving a carrier for the gutta percha, does that make your job harder? I mean, what do you? And there's other brands, aren't there?
Sure. Yeah.
What are the other brands of a carrier? What do you call those? Carrier-based gutta percha?
Yeah, we call them Thermophil.
Thermophil.
I mean, and we just say generically they're all called Thermophil. But
and the people, some endodontists say, well, when you say, what do you think about Thermophil? They'll say, I don't really think about obturation. I think about cleaning and shaping. If you get in there and clean and shape, you can fill it with, quote, bird shit. That's what they say.
Yeah.
And then they'll say, well,
they used
actually, sterile bird shit.
From a sparrow.
From a sparrow? Why a sparrow?
Yeah, it was an English sparrow.
It was an English sparrow. So a lot of old time endodontists say, I don't care what you obturate with. If you get it properly cleaned and sterilized, you can fill it with sparrow bird shit. But back to the question. Obturating. Let's just talk about obturating. There's single cone. You and I had a friend who passed away, Joe Duchesne, who he called himself a squirter. Mm-hmm. He only liked the 3D. It was 2 doors down from me at Creighton in Creighton University. He was a squirter. Some say lateral condensation. Some like Thermophil. Talk about obturation.
Well, I've heard somebody say, endodontists that I trust say, everything in the last 3 millimeters is single cone anyway. So you can tell yourself whatever you want, but you put a main cone in and then you start obturating, whether it's lateral or vertical. That's your main cone right there, and it's hard to do an awful lot different. And I don't know how we know that unless we take out a tooth and dissect it, or take a look at the cleared teeth that we do. But that's been done. I don't totally dismiss Thermophil. My concern is that nothing lasts forever, and whenever you have to retreat it, a Thermophil is a bugger to retreat sometimes.
Sometimes or all the time?
Sometimes. Most of
what
the time.
What percent of the time?
For us, maybe 10% of them
10% of the time
are harder to get out than. Most of the time, we have our techniques to get Thermophil out. We just don't give it a second thought anymore. But sometimes you've got those little plastic carriers at the very end, and it's hard to get those out just because they've deformed with the heat and they've adapted to the canals. But my feeling about Thermophil is one of the reasons it doesn't work sometimes, and I would say it works in the vast majority of the time, I really believe it does, is if you've got a pretty tight canal and you're inserting the Thermophil, the gutta perch and the sealer are peeled off before they get to the apex. And at the apex, all you've got is that plastic rod there. I've done a lot of apicos where I've uncovered the apex, and the only thing there is a plastic rod. There's no gutta percha. So I think that sometimes they fail because they don't have anything really sealing at the end. But that being said, I think no matter how good the seal is, no matter how good the endo starts off, if you have a restoration coronally that leaks, gutta percha doesn't withstand constant bombardment of bacteria, no matter how good it is. So you've got to put it in there, you've got to clean it out, you've got to fill it well, and you got to keep it isolated. And I think if you can keep Thermophil isolated and it's solved the original problem, it's probably going to last a long time.
This is going to be a softball question, and I'm throwing you off a cliff with this, but there's dentists doing everything right. They took out the amalgam, they took out the decay, they did everything right, and they're trying to save the pulp and the whole 9 yards. They do their pulp capping, then the whole thing blows up, and now the patient's all pissed off, and you did a filling, and now it's got to go back and do a root canal, blah, blah. And then I had an endodontist at UMKC who said, you hold the PA, back when it was no digital, you hold the PA at arm length. And if you think it's in at an arm length, you do the damn root canal. And if you sit around worshiping pulps all day, your patients aren't going to be very happy when they blow up on you. And so, but then if you're too aggressive on the, if in doubt, pull the nerve out, then some people might say, well, you're just too aggressive. My thinking is always going to be, well, this person's, most likely every one of your patients is going to live another 10, 20, 30, 40, 50 years. So my question is this, if I've got a pulp exposure and I'm doing everything just right, and let's say the patient my age 53, and the average white male lives to be 74. I mean, all that stuff you did, what's the chances going to be endoed by 74 anyway? And how do you manage the patient's mind? Because mental health is going to make you or lose you more money than their dental health. And if you do too much of the right thing of worshiping pulp tissue, and then these things turn back, like your friend who did a bunch of composites and then they turn endo. So Ed, I know I just asked you 50 questions, but I'm trying to build a deal as where's the line, because these are young dentists, where's the line between worshiping the pulp and then the risk of you didn't do a root canal, the thing need a root canal anyway, and it's after the fact, now the person doesn't trust you, and they're going to live in your zip code for the rest of your life. Is that enough questions for one question?
Sure. Well, I think we ought to respect the pulp. My tooth is better off if I can keep the pulp intact and healthy for the life of the patient. But pulps are expendable. They can be taken out. I just think we have to have a healthy respect for it. And the dentists that I see that are successful set their patients up in a way and say, gosh, this is really deep. I'm thinking that we can do this without a root canal. But we don't know. We're going to have to give this a few days and maybe a week or two and see how it does. But let's try to be conservative. I think patients like dentists to say, I'm going to be conservative with this. And so if we approach it and they think they're not just looking at them and thinking about a cash register, but we're thinking about this really looks like it's what would recommend. This is how I'd approach my tooth. And I used to say, this is how I'd treat my grandmother. Then I'd say my mother. Now to my patients, this is how I'd treat my daughter. But I think if we have a healthy respect for the pulp, we realize it's expendable, we're honest with our patients, we can't do any better than that.
And how long are we out of the woods? I mean, I do all this pulp capping. How long until I'm really out of the woods?
I tell patients that every time the nerve gets worked on or gets close, it can be bruised, and it may take 6 to 8 weeks to go through its symptoms. After 8 weeks, it's not going to change an awful lot because that's how long it takes to have secondary dentin laid down.
8 weeks, you say?
Up to 8 weeks.
So a good rule of thumb, if you're going to do a pulp cap, I want to see you back in 2 months.
Yeah, that's a great way to put it.
And on the bell curve of distribution, how many of that would cover I'm out of the woods?
Yeah, I would say probably 80%, 90% of the time.
89%.
But I do see some of those that they do great, and then 10 years later they need a root canal. Well, then that's 10 years that they went without needing a root canal.
Yeah.
Then I think that the right decision was made.
And do you do any of your root canals today as you did 10 years ago?
Do I do as many now?
No, do you do them the same way as you do 10 years ago? I mean, don't you think you do them better today than you did 10 years ago?
Undoubtedly.
So then the last question, I only got you for 1 minute, so my last question is, sometimes people think too simple and they're told that all root canal teeth need a crown. And then what I see a lot of times, especially with lower anteriors, they did a root canal. They just have this blanket statement that all teeth with a root canal need a crown. And by the time these lower incisors have a constricted cingulum neck, by the time you prep that all the way around, it's basically just gutta percha in your prep. I mean, how do you save teeth by removing the whole damn tooth? I mean,
I agree. I'm in that camp, as you're alluding to right there. I see cosmetic dentists, so-called cosmetic dentists, their teeth look so horrendous. I think, how can they ever sell that to a patient? I tell patients almost all the time, If you have a root canal done on a molar, you need to get a crown. If it's on a bicuspid, most of the time, but I'm going to leave that up to your dentist. If it's a front tooth, most of the time you don't need a crown. And unless you need one, I think I would rather have my own teeth show, especially those lower teeth. They're real problematic.
But can't we both say, after doing this for 3 to 4 decades, that when you prepare an incisor, upper or lower, for a crown, you've totally weakened the tooth and increased the chance that it's going to fracture and snap off?
Yes, you
can
say that.
If you just would have put a composite on the access prep?
Absolutely.
Yeah.
You bet. That's why I tell patients, this is not a foregone conclusion you need a crown on this tooth. If it were my tooth, and I have to be real careful how I word that because I'm trying to support the dentist and the patient. But no, most of the time anterior teeth do not need crowns. If the only reason it needed a root canal and the only breakdown is the access opening, boy, I'd avoid a crown.
Yeah,
on any anterior tooth.
And I can't. That was the fastest hour I've ever spent in dentistry. Gosh darn. I just, you got the most amazing reputation. Everybody loves you. You're so involved in the community. Thanks for turning me on to my first bike ride, 70 miles of precision. But, man, seriously.
Well, maybe we'll have to do this more often.
Thank you so much for all that you've done for dentistry.
You're welcome. Thank you, Howard.